we're going to look at the highlights of an assessment. If you have some insight into the assessment process, then maybe you'll have a better understanding of why a particular product meets an individual's needs. A full assessment, depending on the individual and their needs, may take anywhere from 2 to 3 hours to 2 to 3 days. We'll just be looking at the highlights. A complete evaluation consists of an interview, assessment of functional skills of environments, a MAT evaluation, and a mobility evaluation. We're going to show you highlights of the interview and components of the MAT evaluation. We'll show you how the information gathered can be used by the whole team to identify the solutions. The first step in an assessment is an interview. Team members who are working with a consumer need to get to know this person, their activities, environments, and goals. Hi, Steve. I'm Jeannie Minkel.
Jeannie, it's a pleasure.
So I was interested in why you came to the seating clinic.
Well, primarily it's because I've had an existing breakdown, decubitus ulcer, and it's been going on for now for a good year and a half.
Okay. So while you were here, you had surgery on the wound?
Right. The surgery, I was here for 8 weeks, and then they allowed it to close as much as it could, but they also established that there was osteomyelitis, so again surgery had to be performed to remove the osteomyelitis, and both were done. The osteo was removed and the decubitus was closed completely, and in order to prevent it from occurring again, I definitely have to have the scoliosis corrected, and I've been told that they can work out some type of lateral support that will keep me upright rather than leaning to the right as much as I do. And it's just very uncomfortable, and I can't stay in this seated position long lengths of time, and without constantly moving and trying to sit straight up or hanging my arm over this way.
My interview with Steve gave me the following information. We need to look at Steve out of his chair. By asking him to lift his arms while sitting unsupported, we can assess his balance and see what effect gravity has on his body. We can see that Steve relies on his upper extremities for support. When he lifts his arms, his spine collapses and he falls to the right. Not only has he lost his balance and stability, but he also has a functional deformity leading to pain and uneven pressure distribution. A person with intact neuromuscular system can maintain their position against gravity through the work of muscles, tendons, and ligaments. When the seated person no longer has the internal, intrinsic supports due to a lack of neuromuscular control, the spine collapses. Without this central support at the trunk, it is very difficult to use your arms or legs effectively. Just try standing on one foot and tying your own shoe. By examining Steve lying down on a mat, we eliminate the effects of gravity and can get more information about the skeleton itself. We need to know if the underlying structures are flexible and can be straightened, or are they fixed in an abnormal curve or deformity. The pelvis is the key in sitting. We need to know a lot about the pelvis since it is literally the foundation of sitting. First, we need to feel the pelvis move in and out of a tilted position, from a posteriorly tilted position into an anteriorly tilted position. We want to know if the pelvis can be positioned in a neutral tilt or even a slightly anteriorly tilted position. Steve has a lot of adipose tissue, which makes finding bony landmarks a bit challenging, but this is real life. Steve can be moved from a posterior tilt forward and be positioned in a neutrally tilted position. Tilt is not the only pelvic movement. We also want to feel if the pelvis can move side to side. When one side of the pelvis is higher than the other, it is described as a pelvic obliquity. During the mat evaluation, we want to determine if a pelvic obliquity is flexible, free to move from one side to the other, or fixed in a position where one side is higher than the other. Steve has a flexible pelvic obliquity. His pelvis can be positioned so the top of each pelvic crest is even. The last passive pelvic movement we assess is rotation of the pelvis. Is one side of the pelvis rotated further forward than the other side? Is the rotation of the pelvis fixed? Is the pelvis flexible and either side can be rotated forward and backward? It takes a bit of work to feel, but yes, Steve has good pelvic rotation, so we've determined Steve has good anterior-posterior pelvic mobility. He assumes a pelvic obliquity with the left side higher than the right, but he's flexible and can be corrected, and his pelvis can be easily rotated to either side. After determining the available movements of the pelvis is positioned in the best corrected position as possible. Next, we want to know the available hip movement while we keep the pelvis in this corrected position. We are most interested in how much movement is available at the ball and socket joint at the hip. We do not want the pelvis to move out of the corrected position. The opposite side of the pelvis should be held while the hip is being flexed to feel the pelvis, and stop flexing when it begins to rock. When the pelvis starts to move, the angle between Steve's trunk and leg is measured. This measurement of the angle between his trunk and leg relates to the seat to backrest angle of the chair. Not everyone can sit in a wheelchair that has a 90-degree seat to back angle, because they do not have 90 degrees of hip flexion. What is important is that we know how to test hip flexion range and relate it to the angle between the seat cushion and the backrest. The hamstring muscle is attached to the pelvis, crosses the hip joint, and crosses the knee joint. It is called a two-joint muscle. While we have the hip flexed and the pelvis held in a neutral tilt, we want to see what effect the hamstring muscle has on the pelvis and the lower leg position. If the hamstring is not very flexible, then extending the knee when the hip is flexed will cause the pelvis to rock back into a posterior pelvic tilt. Again, the pelvis is held while the knee is extended to feel when the pelvis starts to pull into a posterior tilt. The angle between his upper leg and lower leg is then recorded. Just as the hip measurement related to the seat to backrest angle of the chair, this angle between the lower leg and upper leg also relates to the chair. The knee extension angle relates to the angle between the seat surface and the footrest. If the footrests are too forward of the front edge of the seat, the hamstrings will be stretched, pull on the pelvis, and cause the user to sit in a posterior pelvic tilt. Therefore, the client who has tight hamstrings and has a small knee extension angle needs the footrest to be positioned close to the front edge of the chair. Now that we know what is happening at the pelvis, hip flexion, and hamstring muscles, we want to look at another movement of the hip, abduction and adduction. When Steve is just lying down, both knees always fall to the right. This is called a windswept deformity. His right leg is abducted in this position, and his left leg is adducted. I need to move his legs to see if they are fixed in this windswept position, or can each knee be positioned in line with the hip. Steve is mobile to neutral, but cannot be positioned with his knees to the left. Let's review Steve's corrected position in a gravity-eliminated position. His trunk can be straightened out, his pelvis can be leveled, his hips flex to 90, and his knees extend past 90 with his hips flexed. Before we look at Steve sitting upright, we should quickly review the anatomy of the spine. The mobility of the spine, combined with the constant downward force of gravity and uneven muscle pull, can lead to some common deformities. There are naturally occurring curves in the spine. There's a small lordosis in the lumbar region, a kyphotic curve in the thoracic region, and a small lordosis in the cervical region. The pelvis sits in a neutral or slightly anteriorly tilted position. When the spine assumes a long C curve from top to bottom, it is described as a kyphosis. Most often, at the bottom of a kyphotic spine, the pelvis is in a posteriorly tilted position. Conversely, when the lumbar curve extends all the way up the spine, it is called a lordosis. The pelvis is most often in an anteriorly tilted position when the spine assumes a lordotic posture. The spine can also be curved side to side. If we look at the skeleton from the rear and can trace a curve to the side, it is referred to as a scoliosis. With many scoliotic curves, we will find that there is also a pelvic obliquity, with one side of the pelvis higher than the other. Now, let's look what happens when Steve sits up and gravity pushes down. First note, Steve needs both his hands to hold himself up. His spine collapses and the right side of his pelvis drops down. From the back, you can see the curve of his spine and all of his weight on the right side of his pelvis. Remember, from his interview, he told us he had a right ischial tuberosity pressure sore. Mechanically, we can appreciate why his skin broke down under the right IT when we see all of his weight falling to that side. From the lying down evaluation, however, we know that these deformities are flexible. The question is, how much force is needed to correct these deformities? Without correcting the pelvis, a lot of force is needed to hold the spine in a corrected position. When his pelvis is corrected with my leg, however, his trunk can be held with a bit less force. What Steve needs then is a properly designed seating system to give him this type of support to hold and correct his flexible deformity. Not all deformities